The University of Michigan Division of Gastroenterology and the Inflammatory Bowel Disease Program host the IBD Visiting Professor Lecture Series in Ann Arbor, Michigan. This series presents the latest in clinical research and basic science from IBD experts from around the world.
So I would like to take this opportunity to introduce our first IBD visiting professor of this academic year, Dr. Simon Travis, who is visiting us from the University of Oxford. He started his medical training at St. Thomas's Hospital Medical School, did research training in both London and Oxford, had a short diversion with commando school and a bit of military service in the 1980s, fortunately not too much near Argentina, and then was a consultant in Plymouth, England, and then returned to Oxford in 2001, where he's revitalized the clinical research there, which has been a long tradition of clinical research stretching back to the very first clinical trial in IBD of cortisone in ulcerative colitis, published in 1955. And along with that, a tradition of developing measurement instruments that have been very important in IBD, going back to the True Love and Wits Index, the Simple Colitis Activity Index that we frequently use in UC, and the Prognostic Index we use for inpatients with CVC, the Travis Index, which all those folks who rounded on the inpatient service are familiar with. And Simon has been elected to the IOIBD and more recently is president of the European Crohn's and Colitis Organization, or ECHO. And he has joined us today to talk about his research on improving the measurement of endoscopic activity.
Gosh. Peter, you embarrass me, but thank you very much indeed. And it's a great pleasure to be in Ann Arbor for the first time, in Michigan, and to be talking about acute severe colitis. And also, this is an international first for the Ulcerative Colitis Endoscopic Index of Severity. So you're the first audience in the world to hear this outside of Oxford, because we'll be presenting it again at UEGW in Stockholm. So one of the great pleasures, and of course I know Peter for a long time through various meetings, and it's always nice to come, and I've been very, very well looked after and met some super people here. But one of the pleasures is that the sun is shining, because this is what it looked like in the UK yesterday, and it was very much to be welcomed that lovely day here, and of course you can see the IBD specialist looking at the problems that acute severe colitis organises. And
looks like that every day last
night. Belisa, I'll go home thinking about that. At Ann Arbor, it is always just the sun is shining. So that's important. That's really important. And the sun shines not just outside, but anyway. And take you back to 1859, the time when probably the first graduates of this great university and medical school were graduating. And there's this guy who, as a young doctor, younger than he is in that picture, but who wrote up this case report of the morbid appearance of the colon of Miss Banks. And you will recognize, as you walk along the corridors of Ann Arbor, a certain sort of similarity with some of the earlier photographs. White, male, long sideburns, and that is him when he became president of the Royal College of Physicians. So we're talking about acute severe colitis, and let's start with names, because people talk about fulminant colitis, but let's be precise, because fulminant colitis was defined by Sidney Truelove back 1950, over 60 years ago, as a single attack going along on to death within 1 year. And that really has no relevance in the second decade of the 21st century. But acute severe colitis has got defined criteria. It defines a course of action. That means admission to hospital. And it has prognostic implications. And that's really important, because when you're managing IBD, you've got to think always of the future. And you need to distinguish, please, when talking about severe colitis, between the biologically severe, the biologically active, and the treatment refractory. It's so easy to fall into, oh, this guy's got severe colitis because he's refractory to steroids, thiopurines, infliximab, and so on. whereas in fact you may only have moderately active disease. So what we're talking about here is that one, it's the biologically severe colitis. And defined, here's the old Radcliffe Infirmary, which actually has just become a mathematical institute because we've all moved to a new campus out of town. It's defined as bloody diarrhea, 6 or more times daily. That's the benchmark, with one of 4 other criteria. You only need one other, and I'll come back to that. Either a tachycardia, a fever, anemia, or an ESR. But those numbers are very, very easy to remember, very easy to apply in clinic because it's very easy to underestimate the severity. And looking at the prevalence, we've just looked at our patients of those who are diagnosed in Oxford and followed up in Oxford, as we have 1,850 odd patients with ulcerative colitis, 1,400 with Crohn's, but of the 750 in Oxford, 186, that's just under 25%, admitted at some stage with acute severe colitis. Very similar to what Dan Turner and Hilary Steinhardt found in Toronto with children, in fact, that it's more common than you might imagine, and that too, single admission, has prognostic implications, which perhaps we'll come back to. And looking at those data, in fact, between the cohort with acute severe colitis there and the cohort who were never admitted with acute severe colitis, so this is retrospective survey, not rocket science, going back through the records, there's really no difference in demographics as far as gender, age at diagnosis, smoking status, appendectomy, or family history. But on the other hand, when you looked at extent of disease, of course it mattered, and that comes as no surprise. Patients with extensive colitis far more likely to be admitted. But what I found interesting was this, that extent at diagnosis was not only an unreliable estimate, but 10% of our patients who were admitted with biologically severe, acute severe colitis actually had distal disease or even just proctitis at the maximal extent. You think, well, what's going on there? But in fact, these are all assessed according to the True-Love-Witz criteria, and of course, infection was excluded. And another question arises whether people who get admitted with an acute episode are somehow predisposed. Now, if they're genetically predisposed, you might imagine that they were admitted, really they had bad colitis right from the start, but it turns out not to be the case. Certainly, the most of those, but still a minority who do get admitted, are admitted within the at diagnosis or within the first year. But actually, if you look at that over the years following, sometimes right here out to the right over 30 years, you still get some people whose first admission was actually years and years after they were diagnosed with ulcerative colitis. And that suggests, of course, there's some sort of environmental factor, and what that is almost anybody's guess. And again, you think of infection, but hey, it's difficult to identify a specific pathogen. And the median time to first admission was just under 4 years. Now, intravenous intensive therapy hasn't really changed in the past decades. I was going to say 50 years, but certainly the initial therapy is will be familiar to people, to senior gastroenterologists and retired gastroenterologists. Intravenous steroids. Heparin thromboprophylaxis, I think, is important because you get 2- or 3-fold the increase of acute thrombosis. That is a routine, debatable, and probably not in children. But the abdominal film is you've got a diameter of the colon, a plain film of 6 or more centimeters. That diagnosed dilatation. It's unusual these days because toxic megacolon isn't some sort of sudden event. It doesn't suddenly appear. It comes because acute severe colitis is neglected either by the patient or their physician. It's all part of a spectrum. Clearly, you send stool for culture, cross-individual toxin assay, which is increasingly prevalent. Liaise with surgical colleagues. I'll have more to say about that. Monitoring, a bit of objective, evidence-based nurses, stool frequency, pulse temperature, and of course the C-reactive protein. And then generally, it has been the tradition, if people aren't responding, they go for surgery. And what that did was to reduce the mortality in 1955 from pre-steroids 24%. Steroids came in and went down to mortality, I'm talking about, 7%. And now it should be less than 1% in specialist centres